I'm going to be the opposite of Kyle and here and need to bring the microphone down some. As Brian said, I'm a pediatric neurologist. I'm specialized in epilepsy and neurogenetics specifically. Some disclosures, I am a consultant for Cortigen, and I'm also going to talk about some off-label treatment in epilepsy. So the point of my talk is to try to bring together the topics of epilepsy, cannabis, and genetics, and how to use the data together to see how we can cater the treatment courses for these patients. So I want to do a quick jaunt through the brief history of epilepsy and cannabis. Hemp was first known as an agricultural crop in modern Taiwan in 8000 BC. But the first recorded use of cannabis as medicine occurred in China about 5 millennia later. And over time, it spread from China out west, east, north, south. Unfortunately, the oldest written recording of epilepsy was in ancient Mesopotamia in 2000 BC, but it was viewed as a psychiatric disorder, possessed by demons type of thing, as you can see some of these drawings. And the treatment was not very good, going anywhere from leeching to burr holes in the skull. So not exactly the most pleasant of treatments. Unfortunately, we have progressed starting in 500 BC thanks to Hippocrates, who defined epilepsy as a medical condition as opposed to a psychiatric condition. And a Greek physician, Galen, a few centuries later, started prescribing medical marijuana in general, not specifically for epilepsy. Going into modern times, Dr. William O'Shaughnessy introduced medical marijuana to Western medicine, including the treatment of epilepsy. So that was the first recorded history of medical marijuana being used for epilepsy. In 1850, bromide was the first effective anti-seizure medication that was introduced by Sir Charles Lockhart. And since then, we have had many more seizure medications introduced to the point where we're over 30 seizure medications now, including 1910 when phenobarbital was introduced as the first synthetic compound, with the most recent being Aptiom. So cannabis was added to the U.S. Pharmacopoeia in 1850 as well, but unfortunately in 1914, the Harrison Act defined marijuana as a crime, and subsequently following, California, coincidentally, was the first state to illegalize marijuana. Then Dr. Raphael McCullum, who we've had the honor of listening to, started research in medical marijuana and started isolating and synthesizing delta-9 THC. And then in 1970, the Controlled Substance Act classified marijuana as Schedule I, which basically illegalized it nationwide. And that's where the problem started. Marinol did become FDA approved in 1985, so that started opening up some doors again. And then the cannabis receptors, CB1 specifically, was discovered in 1988 by Drs. Howlett and Devane. Coincidentally, in 1996, California became the first state to re-legalize marijuana. And then the whole modern progression of medical marijuana started in August 2013 when Sanjay Gupta endorsed the product on CNN program called Weeds and highlighted the story of Charlotte Figi. And GW started their trials soon thereafter. So is epilepsy treatable? I'm saying treatable because most of the time it's not curable. We're basically putting a Band-Aid on a symptom because seizures are a symptom of the epilepsy, which is the disorder. And as you see here, this is a well-known study from 2000 from Dr. Brody. And for the first medication works okay, about 50% of seizure patients become seizure-free. But as you get to the second and third drug, it's getting worse and worse to the point where the chance that when you're on the third drug or higher, it's only about a 3% chance that you're going to become seizure-free, so not very good. So about a third of patients remain what we call intractable, meaning failing 2 or more seizure medications. So I think the best way to highlight all this topic is to go through some case presentations, and I have some videos that are slightly graphic. I tried to choose more of the benign ones, but I think it really brings home the point about what these parents and these families have to deal with. So the first patient is MK. She presented to me at 11 years of age. Her seizure started at 6 months with a high fever after vaccinations, and then she had started having seizures without fever. At her initial evaluation with me, she had multiple seizure types, tried on multiple seizure medications, including oxcarbazepine and lamotrigine. Both are sodium channel mechanisms. The oxcarbazepine or Trilapto made her seizures worse, but the lamotrigine did not, which she's currently on as well. Development was normal until about a year, and then she was subsequently diagnosed with autism and was basically nonverbal. And workup was essentially negative, including basic genetic workup and EEG and MRI changes that were nonspecific. So I knew the diagnosis right away hearing the story. So I asked Cortigen to send the epilepsy next generation sequencing panel. She did come back with a SCN1A de novo mutation, meaning she has Dravet syndrome. She fits that phenotype. I asked them to rush it because the Epidiolex trials were just about to close, and I was running the trials in Orlando at that time. So I was able to get her in quickly. The importance of this mutation is that you have to avoid sodium channel blocking agents because it's a loss of function mutation. In general, though, in a subset of populations, for some reason we don't know yet, and we have to kind of sort this out, is they don't respond adversely to sodium channel agents. But in general, you want to avoid them because it can bring them into status epilepticus. But she was placed into Epidiolex trials. She had an immediate 50% seizure reduction. EEG showed background improvement, which is unusual to actually get a change in the background itself, and she was talking much more and had much more improved eye contact. As an additional example, I have another patient, exactly the same story, diagnosed before I saw her, put in the Epidiolex trial. She was nonverbal, she was eating poorly. From day one we administered the Epidiolex. As the mom was driving home, she all of a sudden spat out, "Mom, I want food." Mom basically slammed on the brakes and said, "Okay." The first visit that she came back to me, I was also floored. She was playing on her iPad, which she was doing before, but I was seeing what she was doing, and she was actually spelling words on the iPad, which completely floored me. Dr. Davinsky kind of went through this data already, so I'll just go look at it briefly. As you see here, they did section out the Dravet syndrome patients, and they did have a better response. So there's a certain subset of populations that is going to respond better to the Epidiolex. And these were the phase 3 data that Dr. Davinsky already went through. So J.A. is another patient of mine. He presented to me at 3 years of age with explosive onset of myoclonic seizures, so basically jerking type of seizures. He also started having drop seizures, atonic seizures, as well as generalized tonic-clonic seizures. And I clinically diagnosed him with Dravet syndrome. With Dravet syndrome, there's no good treatment for it. Some people say ketogenic diet, some say vagal nerve stimulator, but there's no good treatment. He was having seizures so often, by the time we tried him on certain medications, he was having seizures every 7 to 10 seconds. So imagine your life like that. There's no way a child's brain can develop that way. He was tried on multiple medications, including ketogenic diet. He completely regressed. He could not walk, he could not talk anymore, he couldn't even eat anymore. And his workup was basically negative as well. So I wanted to show you a video of his seizures, maybe. Maybe not? Okay. But basically, as you see, his background EEG is very messy, all those big generalized spikes. He basically just dropped or jerked every 7 to 10 seconds, and then he had those big seizures as well. At this point, I really had no more options for this family. I said, well, we can try the vagal nerve stimulator, but the data's not very good on that as well. I did send for genetic testing, and he had 2 mutations come up. One was a CHD2 mutation, which in the literature had just been reported at the time associated with severe myoclonic epilepsy as well. However, it was maternally inherited, so I wasn't sure if that was the complete answer, but I kind of went with that diagnosis for the time being. And mom was asymptomatic, so I wasn't sure. He also had a second mutation, the calcium channel, CACNA1A, which at that time I didn't believe explained his symptoms because it's only been reported with familial hemiplegic migraine and episodic ataxia at that time. But it was de novo, meaning neither parents passed it on, and so that was a little unusual, so I kept an eye on that. But so what we last year, this past December though, there was a few case reports with CACNA1A associated with severe myoclonic epilepsy. So I did talk to the parents about that, but I gave the parents the blessing. They said that we want to move to Colorado and try CBD. I said go because it wasn't legalized in Florida yet. And he, after playing with a few different strains, few different dosing, we finally got him down to about 2 to 3 seizures a day. Remember, this kid was having seizures every 7 to 10 seconds. So that was a huge improvement. Basically, one of the emails the family sent me was just basically they said, he is back. Our little kid is back. He was walking, he was talking again, he's participating in regular classroom settings. He's not quite normal, but he's at least, being able to be integrated into a regular classroom, and he's eating again. So this is him, and as you see, he looks quite normal. You would not have known, like a few months ago, he was having seizures every 7 to 10 seconds. So the calcium channel mutation is interesting because it works on the P and Q type calcium channels. Now, we don't have any seizure medications that work on those channels, but we do have a blood pressure medication that works on it called verapamil. And that's the thing I'm going to try him on next because I'm never happy until the child's seizure-free. So we're going to try this on the child next. We actually have used verapamil in seizures before in the Dravet patient population, and it has helped a subset of those kids as well. So I'm excited to kind of see what happens with him. EC, he's a 6-year-old, global delays noted, typical story, bad motor delays in speech, became nonverbal, diagnosed with autism. He started having seizures, diagnosed at 3.5, mostly tonic seizures where you get stiff all over. He had multiple, he's been on multiple seizure medications. Basically, he's tried everything under the book, and he was having about 40 plus seizures a day as well. Yeah, the first video didn't have that for some reason. So as you see here, interictally, meaning between seizures, he usually has a bunch of spikes you don't see there, but he just has some background slowing. And then what he does is he drops and then he gets stiff, and his background just flattens. And that's a typical atonic-tonic type of seizure. And as remember, he was having about 40 of these a day. And just imagine for a kid that is ambulatory, this is not good because they're falling constantly. They'll have to use a wheelchair. They'll have to wear a helmet. He also had these episodes of dystonia, which the previous neurologist kind of treated him with baclofen. It worked okay. Since infancy, also, he had a lot of GI issues, cyclic vomiting, alternating constipation, diarrhea, problems with weight gain, and also a lot of behavioral issues, very hyper, very aggressive. And that was actually the main concerns outside of seizures for the parents. Workup was basically normal. The microarray showed a chromosomal deletion that I didn't felt fit the picture, so I ignored that. So I also sent the epilepsy panel on him. He came back with 2 mutations as well. One is in the SCN2A, a sodium channel, just like SCN1A, but these mutations are different because they're gain-of-function mutations as opposed to loss-of-function mutations. It was de novo, so it wasn't inherited by either family, but I couldn't completely toss it out. But he doesn't really present with like that. That most of all the SCN2A kids present with seizures under a year of age. So unless the parents completely missed it, he doesn't quite fit that. But I wanted to keep that in my back pocket. The reason for that is if he failed the treatment that we had for him, then I would put him on very high dose sodium channel agents. Even then in the literature, that high dose doesn't get them seizure free, but at least it helps them. But more importantly, and this is a diagnosis I had thought about with him, is he had a SOU6A8 mutation, which is linked to X-linked creatine transporter deficiency, and this was inherited through the mom. This is very important because as opposed to creatine deficiency disorders, they don't respond as well to the supplements. I did think about these things. However, when a local lab gets an order like guanidinoacetate, acetate, they kind of freak out and have no idea what they're ordering and just order something else. So I kept getting the wrong thing. So I actually got these metabolic markers 4.5 months after I got his genetic diagnosis, and they were abnormal. They called me, and I said, yeah, I already know. Okay, so on the left here is MRS. As you see, this is the choline creatine peak, and that's what's normal. And this is the patient's. As you see, his choline peak is much lower than what it should be. His creatine peak is much lower than it should be. But this was important information for me because it tells me that he has some creatine going into his brain. So there is some transporter function. So I said, let's go ahead and try their supplements. We put him on the supplements, and he's been seizure-free since. His GI issues were completely resolved. His improved energy, his EEG basically normalized. He has a few spikes here and there, but not like the bad EEG background that I was seeing before. I repeated his MRS as well, and there was a 50% increase in creatine, but I couldn't go higher on his supplements because if I go higher on his creatine, basically I destroy his kidneys. He, however, did not have any improvements on cognition or behavior, so the parents wanted to try CBD oil. Unfortunately, we did try that, and he's had no improvement, but I was limited in Florida as well about what ratios I could use. So as the laws open up, hopefully they'll be able to try other things. And the next thing would be try those high-dose sodium channel agents. But more importantly, there is a clinical trial in process with a creatine analog specifically for these creatine transported. So there will be no delays in diagnosis with him. Once that trial opens, I can enroll him right away. And the mom was inherited because any future boy she has a 50% risk of having this disorder. TC now is a 5-month-old male. He presented with these episodes of behavioral arrest and losing tone for 30-60 seconds, which only occurred when he was sick. Otherwise, neurologically, he was intact in between episodes. And these were his episodes. The EEG background is very normal. This is during one of his illnesses. And as you see, he has good enough strength to pull him up, but then he starts getting wobbly, and then eventually he'll fall over. And he has a startle response, not a seizure. And he just flops over, and the EEG was normal. But the parents really wanted to know what was going on, and I didn't have an answer for them, but I said, this sounds like an energy metabolism problem. So I said, let's send for mitochondrial. And fortunately we did, because it came back and he had a solute 2A1 mutation, which includes for glucose transporter 1 deficiency. So this kid got diagnosed at 8 months of age, which is one of the earliest ever for glucose transporter 1, and it was de novo mutation once again. Coincidentally, though, they sent me this video the same day I got the genetic report back with these new episodes. And basically, he just has what we call oral automatisms, mouth smacking, lip smacking, and he kind of stares off. So this could be one of two types of seizures, focal seizures or absence seizures. But absence seizures really don't exist in this age group, 8 months of age, with the exception of glucose transporter 1 deficiency. So I got the diagnosis early before he really became truly symptomatic. His EEG came consistent with absence seizures. I tapped him, and his glucose and ratios were low in the CSF. Immediately started him on the ketogenic diet, and he's been seizure-free since, and has no problems with his development at all. He can also be enrolled in the triheptanurine trial if he decides in the future he doesn't want to do the nasty ketogenic diet. But this is important because most of these children don't get diagnosed later in life. I have several kids who come to me at 8, 9 years old or older. They have these severe epilepsies, global delays, movement disorders, which is the typical triad of GLUT1. And by that time, their brain's already destroyed and irreversibly damaged. So they're placed on the ketogenic diet. Their seizures may improve, but their cognitive abilities don't improve. So would this be a case where CBD oil may come into play and help these children? Is cannabis a reasonable option for treating for seizures? We do know it has anti-epileptic properties. It probably has anti-inflammatory properties that are also helping these kids, because these kids are seizing all the time. Their brains become damaged and edematous. So these anti-inflammatory problems will help with that. This is a map from 2006 and 2007, where these are the states that were legalized. We've progressed a lot since then. This is the current map, including Georgia and Virginia that were just approved late last year, and then Pennsylvania, which will also be pushing a bill through as well. So what do we know? It's not a panacea. Nothing is, okay? At least one strain is not going to solve every disorder, and unfortunately, we can't just have one drug company test for one ratio on one type of patient. That will take forever to figure this out. CBD is non-euphoric and non-addictive. It can be effective for many diseases, including many neurological disorders. Sativex in Europe for spasticity, Epidiolex for Dravet Syndrome. It is safe, at least in the short-term data. But what other diseases can it be effective for? We have a lot of anecdotal data and small case series, but very little randomized, double-blinded, placebo-controlled studies. What is the specific mechanism, and what compounds are needed? There's a lot of different compounds in CBD, as you see in the CBD pathway, microcannabinoids, terpenes, and so forth. Different diseases will need different ratios. We do know that, and how much THC is effective, because we do know THC is also proconvulsant, meaning it can cause seizures. And what is the long-term safety data on this compound? We still need a lot of studies. So I just wanted to end with a quote by Hippocrates himself. People think that epilepsy is divine simply because they don't have any idea what causes epilepsy. But I believe that someday we will understand what causes epilepsy, and at that moment we will cease to believe that it's divine. And so it is with everything in the universe. And that's the case today, as we're finding the genetic etiologies of epilepsies and can kind of cater the treatment course of these patients. It can affect the outcome, as with the glucose transporter 1. That diagnosis basically saved this child's life and development. And then genetic testing can be helpful as far as guiding if another treatment is appropriate. So, for example, that glucose transporter 1 deficiency, you want to treat with ketogenic diet first. You don't want to play around with medical marijuana. But we have kids that has a CDKL5 mutation where we know nothing works on these kids. So why mess around and wait instead of just going directly to CBD and testing that? Looking at responders versus non-responders based on the metabolism and the pathways, as well as allowing phenotyping of the compound to determine contaminants. Okay. Thank you for your time.